So firstly, just hello everyone and welcome to the latest of VetCT's 12-minute take-home webinars. It's good to see so many people back again. Hopefully you've had a chance to try the VetCT app up to now. If not, then please do give it a go. The app gives you 24/7 access to a team of friendly specialists across all disciplines. You can choose to communicate with the team via instant callback, text chat, book an appointment at a time that suits you, or request a written report whilst learning on each case. Anyone in the UK will also get the added benefit of real-time CPD. All you do is register for your 3 months trial by simply downloading the app and create an account, or you can contact me directly. My email's on the screen, david.moffat@vet-ct.com, or the team at sales@vet-ct.com, and we'll be happy to help. Right, on to today's 12-minute webinar. As a reminder, the session itself is being recorded and there will be an opportunity to ask questions at the end. So please do add any questions into the Q&A section. You should be able to see at the bottom of the webinar. We will answer as many as we can in the time and follow up with any others after the webinar. So firstly, I'd like to just introduce you to the internal med team. So on the screen at the moment, you will see Dr. Kate Murphy, who's going to be running the session today. We also have a number of other specialists that you can see on the screen there as well. So these are the internal med team of VetCT that you can interact with through the VetCT app. So firstly, let me introduce you now to Kate Murphy, who's going to go through the topic of FIP, how do I try to confirm the diagnosis? So Kate, it is over to you for today's session.
Thank you, David. So what I'm going to try and do is make as clear as I can a particularly difficult topic, because FIP is a very difficult disease to convincingly diagnose. So the first thing really is just to put in mind what we are talking about when we're talking about FIP. And when we talk about the test, you'll remember the importance of just understanding that what we're talking about here is feline enteric coronavirus. And this is a virus that is widespread in the cat population, with many, many cats having been exposed to it and many of them having seroconverted when they've been exposed. When we talk about FIP, we're talking about when that virus has become a systemic infection rather than in the intestinal tract, and often associated with mutations in the virus that allow it to become invasive and systemic. And it then targets the monocytes once it's become a systemic infection. And what this results in that small proportion of cats that go on to develop FIP from their enteric coronavirus infection, is that they develop an inflammatory reaction, which tends to be focused around blood vessels, and it's a mixture of cells. So these are the sort of pyogranulomatous inflammatory lesions that get reported, monocytes, neutrophils, lymphocytes, and sometimes it causes granulomas around the blood vessels, and we can see those grossly in solid organs. Other times it causes a sort of vasculitis type of issue, and we get this leak of fluid, and this is the majority of the cases of FIP that we see where they have effusive or wet FIP. So the way that I tend to approach FIP is having a sort of checkbox-like approach in my mind. So when I'm looking at the history, the physical, the results that I get, I'm trying to see, well, how many ticks in the boxes can I get to increase my sort of likelihood that this is FIP that we're dealing with. So let's look at the different elements that we can use. In terms of ideas from the history, we typically see FIP in younger cats, so cats that are less than 3 years old and more often than not less than 2 years of age. But there is also an older population that we see of over 10-year-old cats. So anything in the middle is unlikely to be FIP. A young cat or an older cat, it becomes on the list of possibilities. We see a higher incidence of FIP in pedigree cats and in cats from multi-cat households. And although it's not infectious per se, because we need those mutations, there have been some reported situations where in contact cats with cats that have had FIP seem to be more at risk of also developing FIP. So whether that's a particular variant, whether it's actually more to do with stressors, and that's another really important thing. In the history, if we look at the history and we see that there's been a recent stressful episode, and that stressful episode could be as simple as the cat coming in to be neutered, or having vaccination, or it's recently been rehomed, or maybe there's been new cats introduced into the household. Those sort of factors are ticks in the box for the possibility of FIP in this cat. When we look at the clinical features, there are some features that are sort of seen with both the wet and the dry form of FIP. And the wet form clearly is easier to diagnose because we've got the fluid to get hold of, and we're going to talk about that in a moment. The dry form is a little bit more insidious and a little bit more secretive, so more tricky to make a definitive diagnosis. But with both forms, the sort of classic features are those non-specific clinical signs that we see in cats of lethargy and anorexia, often associated with some weight loss. And then a more sort of defining feature is that these cats tend to have pyrexia, usually greater than 39.5, and a sort of persistent, although maybe waxing and waning pyrexia. So FIP is a really important differential for pyrexic cats, and a few weeks ago we talked about pyrexia in dogs and cats, and that was one of the considerations to have there. Some of the other features that we'll see with both wet and dry FIP is that they may become jaundiced. It tends to be maybe a little bit more common in the wet cases that we see them becoming jaundiced. And we can have a sort of non-specific lymphadenopathy, often of the internal lymph nodes. And then when we look at the wet form, it's really the classic aspect that we're getting an effusion somewhere in a cavity, most typically in either the chest or the abdomen, but occasionally we'll see effusions such as pericardial effusion or even scrotal effusions. So those can be less typical signs, but still something that is reported with wet FIP. With the dry cases, it's more sort of vague signs. So, for example, they might present with neurological signs, they might present with ocular signs, and that can be uveitis, or we can have sort of changes affecting the vessels, so a chorioretinitis as well. So really important in a pyrexic cat, particularly if we come on to some of the other tick boxes on the bloods, that we do have a good look at the back of the eyes and into the anterior chamber and see if we've got any evidence of features that could fit with an inflammatory disease there, of which FIP would be one of our differentials. We'll also sometimes see sort of focal intestinal masses or focal lymph node enlargement in the abdomen, and that can also be a feature with FIP. So those are the sort of historical and clinical features that we're looking for on our physical exam and our history. The next stage when we're trying to identify a cat with FIP is to move on to some basic laboratory diagnostics. And the sort of features that can be ticked in the boxes here are often these cats will have an anemia of chronic inflammatory disease. So what we're talking about there is an anemia that's not particularly severe, it's non-regenerative, and we're not finding an obvious cause for that anemia. There are some cats that are reported to have microcytosis, and that can be either associated with anemia or actually a non-anemic cat. So that's another sort of feature to just consider. Although, to be fair, microcytosis is relatively difficult to assess in cats because their red cells are so small anyway. When we look at the white cell picture, we typically see a leukocytosis due to a neutrophilia, and these cats will typically have a lymphopenia. So it's, again, just a tick in the box, not a specific finding for FIP, but a feature that we tend to see. One of the really important ones is where we see hyperglobulinemia, so increased globulins in the peripheral blood, and usually resulting in a total hyperproteinemia as well. If we look at the albumin globulin fractions and we look at the albumin globulin ratio, then a ratio of less than 0.4 makes FIP very likely. Conversely, if you have an AG ratio that's more than 0.8, then it's highly unlikely to be FIP. So using those two extremes gives us a reasonable probability for or against FIP. If we're in the middle of that zone, then it doesn't tell us anything one way or the other. But the hyperglobulinemia is an important feature. It's not present in all cases. You're probably looking in up to about 90% of cases, though, will have that hyperglobulinemia. And then we see this increase in bilirubin, which may or may not be to a level to cause clinical jaundice. Often it will just be at a lower limit, so we'll only pick it up on our biochemistry, but that's present in up to around about 60% of cases, but with a wide range, and it is more typical in the wet form. And then we can see other changes on the biochemistry. So we may see changes in the liver enzymes. We may see changes causing azotemia. So there are other features, but these would be the classic ones that we're really looking for on our ClinPath to give us an indication. Now, there are some additional tests that we consider, and we're going to come to the more specific coronavirus test in a moment. But other things that we might consider doing, well, if we have got a hyperglobulinemia on our basic bloods, we could submit the blood for a serum protein electrophoresis. And one of the ticks in the boxes there is we're expecting with FIP to see a polyclonal gammopathy. So when we get a hyperglobulinemia, our major differentials are, is this a neoplastic monoclonal gammopathy, or is it an inflammatory gammopathy where it will be polyclonal? there are some things that don't fit the strict criteria there, but FIP should be polyclonal. You can measure alpha-1 acid-glycoprotein more specifically, and if that's above 1.5 milligrams per mil, then that can be consistent with FIP, but it's a non-specific marker of inflammation. So it's not FIP specific, it's just a tick in the box. And then, of course, we can combine our diagnostic imaging. That may be X-ray, CT, ultrasound. And here, really, we're looking for evidence of disease, either causing effusions, in which case, not only do we want to identify them with our diagnostic imaging, and ultrasound will be a superior method here, nice and fast, patient side. We want to sample those effusions, and then we'll look at the analysis of that fluid in a moment. If, however, we haven't got any fluid anywhere, it doesn't rule FIP out, because we could have the dry form. And here we'll be looking to see, well, have we got any changes in the organs, such as the kidneys that might be granulomas? Have we got any intestinal masses or any lymph nodes that are enlarged? And can we sample those? For the cats that present with neurological signs, we may want to think about advanced brain imaging and CSF analysis. And we'd expect with those to see diffuse inflammatory changes and to see a high protein level in the CSF and a mixed cell increase in there. But those are the lesser number of cases that you're going to see clinically. So let's look at the coronavirus tests, or what often gets termed incorrectly an FIP test. So one of the screening tests we can do is coronavirus serology. It's not FIP antibodies, it's coronavirus antibodies. And so what we're doing here is testing to see whether an animal has been exposed to coronavirus and whether it's seroconverted. If we get a positive titer, that's all we've got evidence of, exposure and seroconversion. And I've told you right at the beginning that coronavirus is widespread in the feline population, and more than 95% of cats will seroconvert within 2 to 4 weeks of exposure. So when we do a coronavirus serology, we're almost expecting a positive result. So it's typical in FIP cases to have a high coronavirus titer, but they can have any level of titer, and so can any normal cat. We don't vaccinate against FIP in the UK. It's not recommended as a core vaccine anywhere in the world. So you can get antibodies with that, but it would be a rare reason. Now, the other converse aspect is if we get a negative titer, that doesn't actually, I'm afraid, mean we can rule out FIP either, because there's around about 10% of cases with feline infectious peritonitis that will have a negative coronavirus titer. And there's a couple of different reasons. Maybe they've got antibodies that are being lost in the effusion, or maybe there's just so much sort of virus, there's binding of the antibodies and they're not getting a positive test. So a negative doesn't exclude it, although it maybe makes it a little bit less likely because of the percentages that we're talking about here. And a positive just tells us they've met coronavirus and they've converted. It doesn't tell us they've got FIP. If we've got fluid, we want to get a sample of that fluid. And what we're looking at there is it typically tends to be yellow in color. It tends to be quite viscous because it's a protein-rich fluid. And when we do the analysis of the fluid, we find that it's got a high protein content, often greater than 35 grams per litre. So it sort of pulls it into what we classically call an exudate. And if you look at the proportion of the proteins in that fluid, typically it will have more than 50% proteins. And again, it will have that AG ratio that's less than 0.4. Those are sort of good tick boxes for FIP. If the AG ratio in the fluid is more than 0.8, it's got a high negative predictive value. So it makes FIP very unlikely in those cases. Slightly conversely, compared to normal exudates, with FIP, we tend to have a sort of lowish cell count, so typically below 5,000 cells per microliter. And again, mixed bag of cells, the neutrophils, macrophages, and lymphocytes. But it's not the high cell count that we typically see in infectious peritonitis caused by, say, sepsis or something like that. So that's the classic difference here, is the lower cell count, but with the high protein. We can also measure alpha glycoprotein in the fluid, and similar sort of cutoff levels really to the blood, but finding a high alpha-1 acid glycoprotein in the fluid has quite a high sensitivity and specificity for FIP, but it's not definitive. Another thing we can do, and we're going to talk about this in just a moment, is we can also do PCR on the fluid, and finding a positive, again, gives evidence to systemic coronavirus infection, and with other ticks in the boxes, helps to increase our sensitivity that this is likely to be an FIP infection, but it's not absolute. And there are some other tests that can be done, things like the Revalta test, but they're not particularly sensitive either. They're good at ruling it out if you get a negative Revalta, but not necessarily good at ruling it in. So the coronavirus PCR is something that's been added in recent years, and often on labs might get termed an FIP PCR. It's not an FIP PCR. Just like the antibodies, this PCR is detecting feline coronavirus, and it doesn't necessarily detect the FIP. Now, quite a lot of these PCRs will also offer additional tests to look for mutations, and if the mutations are positive, it again increases the probability that this is FIP, but it's not 100%. The PCR can be done on a variety of different types of samples. So it can be done on blood, it can be done on feces, fluids, and ideally fresh tissue. Formalin-fixed tissue, it decreases the sensitivity of the testing, so it's really advisable to keep some fresh tissue for this rather than sticking everything in formalin. And the best sensitivity really would be on a fusion or tissue rather than blood or the feces. So when we get a positive coronavirus PCR, what does it mean? It means we've got feline coronavirus present in that sample. And if it's in something like blood, and a fusion or a fluid or a tissue, then it indicates we've got systemic feline coronavirus. And with other ticks in the boxes, we can move towards an FIP diagnosis. If we get a positive result on feces, all that tells us is this patient is shedding coronavirus in the feces at this point. It's nothing to do with FIP. So it's not a good screen to say whether this cat is likely to go on and develop FIP. It just says they're excreting. It means they're at a risk for contaminating the environment with coronavirus and infecting other cats with enteric coronavirus. One thing that can be helpful, apart from just the mutations being present, is if we have a quantitative PCR and we have high levels of the viral antigen in the sample, then again, it's more supportive of FIP compared to low levels. Now, if we get a negative result on these PCRs, it tells us that coronavirus is not present in that sample. And if we do that on an effusion and it's negative, it makes FIP pretty unlikely. Not impossible, but pretty unlikely. So it's all about weighing things up and getting our orders. We can get false negatives on the PCR. So for example, if it's the wrong primer or if there's a mutation that PCR doesn't pick up. But as it goes at the moment, as a relatively non-invasive test, it's a pretty good add-on, as long as we remember it's only telling us we've got coronavirus present. It's not an absolute for FIP. So the final bits and pieces that we can do, we can have biopsy samples. So we can take tissue if we've got granulomas in tissues, and we can do histology. And we'd expect to see pyogranulomatous inflammation around the blood vessels. If we want to try and confirm that that truly is FIP, then we can ask our lab to do immunohistochemistry. We can also ask for immunocytochemistry on things like our fluids, so CSF and effusions, to identify that we've got feline coronavirus in the macrophages in those samples that are submitted. And if we find them, that's a big tick in the box. The problem is that the sensitivity of these tests for detecting the feline coronavirus antigen is not that great. We're looking at maybe a 30% sensitivity in fine needle aspirates, up to around about 60% in CSF and tissues. So we will unfortunately miss a number of cases with that, but the specificity is okay. It's in the sort of 80s for it. So it's something we can do as an added tick in the box if we need to. So essentially that summarizes my sort of approach to FIP. It's trying to get as many ticks in the boxes as I work through the history, the physical, and the lab diagnostics that we can do. And hopefully it's clarified, or if you've got questions, you can put them in the box if I haven't clarified them, what the individual tests mean. So thank you for listening, and I'm happy to take any questions you may have. If you can put those in the Q&A box, preferably over the chat box, that would be the easiest way for us to answer those. And if there are no questions, then I'll just thank you for attending. But I'm happy, we'll stay live for a few moments to take any questions that you might have.
There must be a question.
It can be a question on anything. I'm pretty open to answering. It doesn't even need to be FIP.
That sounds like you've covered everything for everybody.
Okay, well, thank you all for attending. I'll pass back to David.
Yeah, fantastic. Thank you for that. As I said, if there are any questions, throw them in. We're still here for a couple of minutes, but otherwise that was perfect timing. Thank you, Kate. Very interesting, and thanks everyone also for attending. Please do keep an eye out for any future sessions. We'll be running these up until the 1st of September currently. Next week, we have one on Wednesday, the 21st July at 1 p.m. UK time. This is be on having a clinical pathology webinar on acute phase proteins. Are they clinically useful? This, as I said, will be at 1 p.m. UK time, so please do register ahead for that one. This recording will also be available on our website and YouTube channel shortly. Finally, don't forget to download the app if you haven't done so already. And otherwise, I thank you all for attending and see you next time.